And we have just launched this week the new report, as Cedrian said, The Urgency of Now, AIDS at a Crossroads. It reminds us that the world has a choice, as do we here in Asia and the Pacific. We can act now to end AIDS as a public health threat by 2030, which means by the end of this decade, we need to keep people living with HIV healthy and to slow new infections to a trickle. Over time, AIDS-related deaths should become obsolete, and as fewer people are infected, the cost of HIV treatment will steadily fall. Or we can continue doing what we're doing now, implementing some best practices but not others, spending money but not always in the right areas and amounts, prioritizing treatment but not prevention and human rights. But where would that take us? It will mean higher and higher costs, to expanding epidemics that affect different groups of people in our countries, and possibly to yet another existential threat to our societies and economies in some of the countries. The 2025 Global AIDS Strategy targets are ambitious, but they are not wishful thinking. We know this because 9 countries have already achieved the testing and treatment targets. 4 countries from Asia-Pacific are treating more than 80% of people living with HIV. Cambodia, Nepal, New Zealand, and Thailand. Nepal is also among the 4 countries globally that have reduced new infections by more than 75% and can potentially reach the 90% target by 2030. They're well on the way. Others could learn from their approaches. 18 countries and territories have eliminated mother-to-child transmission, including 4 in our region: Malaysia, Maldives, Sri Lanka, and Thailand. One of the key approaches of the Global AIDS Strategy is U equals U. Undetectable equals untransmissible. This means that when a person living with HIV takes their medicine so the level of virus in their blood is undetectable, there is zero, and I repeat, there is zero chance that they can transmit the virus. That's a game changer in so many ways for people's lives, for our communities, for our countries. The lower the viral load, the lower the chance of transmission. The report contains evidence which further proves this. The graph to the left shows the global distribution of people living with HIV. Green represents people on treatment who have an undetectable viral load, significant proportion. Yellow are those on treatment who are achieving viral suppression, but pink is for those who have not yet achieved viral suppression, and red refers to those who are diagnosed but not on treatment, and the darker red represents people who are not yet diagnosed. The bar on the right shows the risk of sexual transmission. As you can see, most transmissions occur with people who do not know they are living with HIV. But there are also significant transmissions amongst those who are diagnosed but not on treatment, and those who are on treatment but have not yet achieved viral suppression. This is why we have a moral and a public health imperative to help people learn their status, provide testing, start them on treatment right away if they are positive, and to ensure that the treatment works completely and they're able to access treatment throughout their lives. Then we'll see U equals U in reality for many more people, and this will have a significant impact on the direction of the epidemic in our countries and regions. In light of what's happening and what's possible, Asia and the Pacific are seriously underperforming. In 2023, 78% of people living with HIV were aware of their status. That means almost a quarter, though, of people living with HIV don't know their status. And as we've just seen, their chance of transmitting the virus is highest. 67% of people living with HIV were on treatment last year. 65% of all people living with HIV had achieved viral suppression in our region. So roughly 1/3 of the people living with HIV in our region are not getting the care they need and the support they need to stay healthy and to prevent HIV in others. Asia Pacific has the world's largest HIV epidemic outside East and Southern Africa. In 2023, there were 6.7 million people living with HIV in the region. To achieve the global prevention target, Asia-Pacific, with its huge populations, will be absolutely critical. But we must lift the game. We must do more and do it faster. AIDS at a crossroads. Which pathway are we taking? This region accounts for a quarter of new infections in the world last year, 23%. In 2023, there were 300,000 new infections in our region. But progress has stalled. As the bottom graph here shows, since 2010, there has just been a 13% reduction in new infections for the region as a whole, far lower than the global average decline of 39% seen in the top graph, and starting to get further away from that each year as we report. We are not getting closer to the epidemic control if every year a significant number of people newly acquire HIV, requiring lifetime treatment. There were 150,000 deaths due to AIDS in our region last year. Since 2010, AIDS-related deaths in Asia-Pacific have declined by half, but are still far too high. Both new infections and deaths in 2024 estimates show no significant change between 2022 and 2023. This is a serious warning sign that momentum has been lost and that more has to be done to serve the people that our prevention and treatment services are not yet reaching. But perhaps the issue is that the percentages don't drive the point home clearly for us. This is the reality. Every 2 minutes there is a new infection in our region. In the short time that I've been speaking with you, 3 more people contracted HIV. Every hour, 35 people contract the virus, including 9 young people. Every day, more than 300 men who have sex with men, 80 people who inject drugs, 50 sex workers, and 15 transgendered people get infected with HIV. Every hour, 17 people die due to an AIDS-related illness. 17 people every hour. And every day we lose 9 young people between the ages of 15 and 24. These are all avoidable, as we know. So now let's look at what's happened on a country-by-country basis since 2010. The graph to the top shows new infection trends by countries, the countries that are providing reports. There are growing epidemics in Bangladesh, in Laos PDR, in Papua New Guinea, in Afghanistan, Fiji, and the Philippines. The increases in Bangladesh and Afghanistan look small in terms of percentages, but are more significant in terms of absolute numbers. When we look at mortality trends on the bottom graph, we see that all 6 of the countries with rising infections also have growing death rates. But AIDS-related deaths are also increasing in Mongolia, in Indonesia, and in Pakistan. In 2022, in Asia-Pacific, 4 of every 5 new infections, 79%, were among key populations and their sexual partners. Most of these cases were in gay and other men who have sex with men, with 43%. And this is the population with the most growth in the epidemic. According to this report, across the region, new infections increased by 32% among men who have sex with men since 2010. 1 of 5 new infections are in the remaining population. That's people who are not from the key population communities, or they're people who are having sex with people from these communities. As some countries' epidemics mature, we're also seeing the emergence of more mixed epidemics, meaning both key populations and other members of the wider population are significantly impacted. The transmission patterns between and even within countries are distinct, and I'll speak to that in more detail about what's happening in these countries. In the Philippines, it has Asia-Pacific's fastest growing epidemic and one of the fastest in the world. There were 6 times more new infections last year than there were in 2010. That's primarily epidemic among men who have sex with men, and particularly young MSM. New infections in Fiji have increased also by 241% since 2010, and there are indications that these new infections are partly driven by an uptick in intravenous drug use. And the spike in new infections is particularly since COVID. In Papua New Guinea, new infections have doubled since 2010. While key populations remain highly vulnerable, there is now a need for attention to other groups. Every day in Papua New Guinea, 5 infants are infected with HIV. The fundamentals of designing an HIV response remain true. We must first understand the dynamics of the epidemic in each and every country before we can craft our interventions. And often we need to understand the dynamics that are different from our urban and our rural areas across our countries and apply different approaches. A key element of these dynamics in Asia Pacific is related to young people between the ages of 15 and 24, and particularly young key populations. As the bottom graph shows, around 1/3 of new infections in Vietnam, half in Myanmar, Indonesia, Philippines, Thailand, Cambodia, and Laos PDR are among young people. To the top left, you see we have rising new infections among young people in some countries, particularly Papua New Guinea, Afghanistan, and the Philippines. And HIV prevalence amongst young people who have sex with men has at least doubled in Malaysia, in Indonesia, and in Vietnam. Access to combination HIV prevention and treatment services among key populations remains limited, unfortunately, across many countries. Data from reporting countries show that just about half of sex workers now access targeted prevention services. About 1/3 of men who have sex with men and transgendered people in reporting countries are receiving services. Access is even lower for people who inject drugs at 21%. And yet in our region, we require most of the world's opioid agonist therapy interventions. Yet most countries have very low coverage. The median is just 9% coverage. We're hearing here at the conference about the great opportunity of long-acting injectables, both for treatment and for prevention. Pre-exposure prophylaxis, or PrEP, are HIV's drugs that prevent people from contracting the virus if exposed. We have them available in our region, and we'll have new formulations and this long-acting injectables available soon. Not as soon as we'd like it, but they will be there. But we're not seeing the uptake. PrEP has the potential to markedly lower new infections, but Asia Pacific needs to pick up the pace, transitioning from pilot projects, which are not needed today, to national rollout. We will definitely not see the expected payoff from investment in PrEP unless it's implemented to scale. We also hope these new innovations of long-acting will make it easier for some people to access PrEP who don't have to explain why they need a pill a day or why they're doing different things. They can do it much more effectively with this new approach. We have a mixed picture where some countries are accelerating progress, others have some significant plans for expansion, and yet while others' rollouts haven't yet got any national traction, they're far too small and localized. There's a huge gap of 98% to reach the 2025 PrEP target. There were just 204,000 PrEP users in this region last year, far short of the 8.2 million target. When we come to treatment coverage, again, there are wide variations, as you can see in this graph. Several Asia-Pacific countries are not even reaching half of the estimated people living with HIV for treatment. These include Bangladesh, Indonesia, Islamic Republic of Iran, Mongolia, and the Philippines. 3 countries treated less than 30% of people living with HIV in 2023 in Afghanistan, in Pakistan, and Fiji. The majority of Asia-Pacific countries are, though, somewhere in the middle, between 50 and 80% treatment coverage. But they also need to increase their pace. It is now that we need to see this action to have an impact on the epidemic and on people's lives. Every gap to the treatment target represents our risk of losing more lives and increasing new infections in our region. We were at the forefront of the response decades ago. We have stagnated and are going backwards in terms of the response. So which pathway are the countries taking? In this slide, the blue bars show the proportion of people living with HIV who know their status and are on treatment. The grey segments represent people who are diagnosed, but not on antiretroviral therapy. As we learned at the start of my presentation, this dynamic also fuels HIV transmission. Around 1/3 of diagnosed people living with HIV in the Philippines, in Malaysia and Pakistan, half in Fiji and 2/3 in Afghanistan are not on treatment. To the other extreme, we see that it is possible to ensure that almost all people who test positive are linked to care and receive antiretroviral therapy. Cambodia, Bhutan, New Zealand, China, Japan and Thailand are all treating more than 90% of diagnosed people. A great success. Very different countries, very different health systems. So there's no excuse to say it can't be done in any of our countries. So why is it that even where treatment services are available, people get diagnosed and then disappear into the shadows? This brings us to the social and structural factors that drive people away from HIV services. There are legal barriers to the HIV response across the region. We talk about this every year. We see some progress, but not anywhere near enough. 38 countries criminalize some aspect of sex work, 17 criminalize same-sex relations, and 28 criminalize drug possession. 20 countries criminalize HIV transmission still, exposure or non-disclosure, while 14 restrict entry, stay, or residence of people living with HIV. This is an irrelevancy in today's world with the treatments that are available and the prevention services that should be in place. It's the countries that need to show the leadership on this and not seek to criminalize or penalize the people. For people from key population communities and those living with HIV, these are real reasons to remain fearful and hidden. And this is why we're seeing rising infections and increasing deaths in some of the countries. There is an interplay between these laws and the societal attitudes that manifest as what we refer to as the stigma and discrimination. This directly undermines health and well-being. This slide shares select findings from Stigma Index 2.0 reports and behavioural surveys. These are just examples. We see that 38% of men who had sex with men in Yangon, Myanmar, avoided accessing healthcare due to stigma and discrimination. In Thailand, with a very progressive and open response to HIV, yet a quarter of young people living with HIV reported HIV-related discrimination in health settings, while 59% of people living with HIV in Iran said they experienced stigma and discrimination in the community. Violence also remains a factor for HIV. 14% of sex workers in Cambodia reported experiencing physical or sexual violence in the last 12 months. Almost 3/4 of women who use drugs in Malaysia do not get the reproductive health care they need due to stigma and discrimination. And in Vietnam, less than 5% of people living with HIV seeks redress when their rights are violated. This is another reason why our countries need to work on campaigns around U equals U to explode the myth that HIV automatically equals death. This whole message about being on treatment, achieving viral suppression means zero transmission can change the dynamics and address community stigma. Over the last decade, external funding for HIV programs in our region have decreased by 60%, while domestic resources increased by a significant 47%. The report tells us that 12 of the 17 countries analysed rely on international sources for more than 50% of their prevention financing. This is a serious problem if we're looking at sustainability. The region's high donor dependency for prevention may be a looming crisis for us. We know that the global economic situation is affecting financing for health programs widespread, and that's impacting on HIV. So while we applaud the increased domestic allocations, most of that money is going to treatment and commodities. At the same time, we are seeing dramatic reductions in international funding for prevention and the enabling environment work that's so critical. More resource mobilization is needed, especially as the report projects that the number of people living with HIV in our region will more than double by 2050. So we must quickly address both the investment gap in the region, when it comes to spending on key population prevention, not just the available overall resources, but where is it allocated? Where is it used to have the biggest impact? This graph shows that in 9 of the countries with available data, out of total HIV expenditure, they are spending less than 15% on key population programs. So we need governments to invest in more prevention for the right groups in the right places. And with the new tools, it's much, much cheaper and much, much more effective, while at the same time mobilizing to express concern about the inadequate donor support. We need collective action by countries in programs like the Global Fund for AIDS, TB, and malaria to make sure the needs of HIV in this region are not forgotten. How do we hold on to foreign investments where possible, keeping them strategic and focused? There is clear guidance on how more of that money should be invested. The Global AIDS Strategy calls for 30% of testing services, 80% of prevention services, and 60% of societal enabler programs to be delivered by community-led organizations. Their programs are much cheaper and much more effective than many of the programs that our governments implement. But as the bottom graph shows, in Asia-Pacific, most countries don't have policies that enable community and key population-led organizations to be registered and provide the services. So they can contract private companies, but the system is not allowing them to contract those who could be most effective, these community organizations themselves. The common theme of this story is inequalities across the board of what I discussed this morning. Inequalities between countries, inequalities of key populations, and even inequalities between the key populations. Think back to the different levels of service access for people who inject drugs in our region. To address disparities in access to healthcare, HIV services and funding, we must confront these disparities. And I do not refer only to service delivery. I mean the very strict strategies needed to address the disparities in socioeconomics, in the political and legal systems that leave entire countries and communities behind. I also refer to the different economic outputs and resource needs within our region. Not all countries are the same. The impact of COVID is still being felt. Which countries' gains can be threatened by sudden reductions in international investments? We need to prioritize and advocate globally. And which countries are overdue for significant and deliberate donor support to address the tragedy of inadequate service access? For our region, UNAIDS has 4 broad priorities. The first, to renew and intensify the focus on key populations, to ensure that we are reaching the right groups in the right locations with the right interventions and at scale, not like PrEP today. Modernize service delivery. Make full use of the prevention, the diagnostic, and the treatment tools that we have at our disposal. We are so advanced in the type of programs and the diagnostic tools and treatment available, but they're not being implemented at the scale we need. This includes PrEP, the self-testing, community-based testing, harm reduction, and U=U. To eliminate barriers to equitable program coverage, this will entail reforming laws and policies that are hampering access to services for key populations. Some countries are even looking at bringing in new laws that will make this worse. This is the wrong time to go backwards. It's also about education and dialogue necessary to build more accepting and safe societies, not just for people at risk of HIV, but for many others in our societies. We must do more on this. Finally, we must mobilize sustainable financing for the HIV response, and sustainable means political leadership, the right programmatic mix, and the resources needed to make effective impact in each and every one of our countries. It also means investing more in prevention and community-led models for the service delivery. Not only do we have the means to end AIDS, we have a winning strategy, but what's missing is consistent political commitment. If we do not act now, the promise of ending AIDS by 2030 will slip away, and we need to get countries and communities back on track and on the right path.